Okay, hello. So today we are going to talk about diabetes mellitus, and I'm going to, for the first 2 hours, go through, review some pathophysiology, discuss diagnosis of diabetes and what that means, and some of the complications. So some pre-work that I have for the students is to previously review Dr. Malhotra's slides from last spring on diabetes pathophysiology. I believe this will be helpful in reviewing the physiology. I do know that this slide sounds like there's 100 slides and it's in some good detail, so they should just focus on major key points, which I'm not sure if I should provide them key points from his slides or I should just ask them to review previous work. And then with focus on looking at DiPiro, focusing on the pathophysiology section, which I will provide page numbers and other section titles. Once I look at their version of DiPiro, I have an older version, so I know the page numbers are off. I'd also like them to come to class familiar with the action of the following peptides, so including insulin, amylin, GLP-1, and the other, or as an example of incretin and glucagon, and describe how those terms work to regulate blood glucose in the healthy adult. And that should help prepare them for much of the patho discussion. So objectives for this lecture is to identify the different classifications of diabetes and the classifications that differentiate them, describe the mechanisms by which glucose is regulated in the body, explain the differences between normal glucose regulation and that which occurs in patients with type 1 and type 2, given a patient case, appropriately classify a patient as having diabetes based on diagnostic criteria, and identify potential long-term complications of diabetes that should be managed given a patient case. And so I'd like to just convey to them that I hope that this lecture will help to prepare them for John's lecture, which will discuss the treatment. If you understand the pathophysiology behind the development of diabetes, you should understand how and where the drugs work. And the two should complement each other rather nicely. So our overview for this portion of the course will be to discuss an overview of diabetes, go into detail over the pathophysiology and of diabetes, as well as discussing the classifications, how diabetes presents, and what screening tools we have available, discussing diagnostic criteria, and then going into what our treatment goals may be, and identifying potential diabetic complications and how we might prevent the progression of diabetes. So hopefully we can stick to this flow. So first, what is diabetes? Diabetes we know is one of our chronic conditions characterized by an absolute lack of insulin or relative lack of insulin with an impaired insulin secretion and or action. And we'll get a little bit more into detail about those differences when we start to classify our different types of diabetes. So we might also know diabetes as a systematic glucose intolerance, or in other words, kind of a chronic hyperglycemia. And this chronic hyperglycemia can lead to alterations in lipid and protein metabolism, and those alterations chronically can lead to long-term complications with various organs, which we think about changes in our eyes, damage to our kidneys, cardiovascular type complications, as well as nerve damage. And we'll get into more detail about those complications later in our lecture today, and then some more on Friday. We'll talk about more about that. One thing I want you to keep in mind as we move through all of our lectures in this block concerning diabetes is that diabetes is not just a diagnosis. And it's not like some of your other disease states that you learn about where there's a simple pharmacologic or other therapeutic option for treatment. We give that treatment and the issue goes away. Diabetes is very multifactorial and involves many different aspects of a patient's life. When they get diagnosed with diabetes, they really are having to adapt many facets of their life to fit that diagnosis. So we might see necessary changes in terms of activity level and diet and other lifestyle type issues, which you'll talk in detail about later with Dr. Foley. Additions or optimization or changes in medications in order to help control diabetes, as well as other risk factors that are associated with diabetes that we'll talk about later. Medications themselves and constant glucose testing is going to have a significant impact on their daily routine. Fear or dealing with current complications of diabetes, all along with social, psychosocial, and financial burden, which is going to affect the degree and different treatment options. So, as you can see, diabetes is very multifactorial. Often, patients with diabetes are seeing multiple providers that are all helping to provide care in one of these facets. And so you'll see many patients with diabetes are being treated in a team-based approach. And often this is necessary to optimize diabetes care, since it is so cumbersome and so complex. So who has diabetes? Per our National Diabetes Statistics Report put out every year by our CDC, as of 2012, about 30 million people have been diagnosed with diabetes. That's about just under 10% of the U.S. population. As you can see from this data from 2012, we have an astonishing number of cases that were diagnosed just in 2012 alone. So if we look at that number of 20 years or older, that's 1.7 million people diagnosed with diabetes just in that 1 year. That's a 7.8% per 1,000 patients that are diagnosed with diabetes cases. And then you can see that number more specifically broken down into different age brackets, with our middle-aged 45 to 64-year-old patient group taking the lead there. So just thinking about how large of a number that is, 1.7 million new cases every year, you can imagine that diabetes, or patients with diabetes rather, are things you're going to encounter in no matter what aspect of pharmacy you end up in. Whether that's going to be your retail setting, your hospital setting, your clinic setting, your industry setting, your nursing home setting, your consulting setting, pretty much anywhere you end up, you're going to have some interaction with patients with diabetes or the disease state in some manner. So, not something that you're going to get away from. So, very important to understand how it works, so that way when you have patients that do have diabetes, you're able to work with that diagnosis along with others that they may have. As you can see from this map of the world, diabetes is not just selected to the United States. However, you can see that about 39 million people are living with diabetes. So this is slightly higher than the numbers on the previous slide, but this takes into account patients that may or may not be diagnosed. So the prevalence in the United States is about 11.4%, and if you take a gander at all around the rest of the world, that is the leading prevalence. So the United States leads the world in terms of diabetes prevalence, something to be proud of. If you take a look at the other areas of the world that are have a high incidence of diabetes, you can see that will often relate to our high-risk populations that we'll talk about when we talk about risk factors in a little while. And that includes people that come from the Pacific Islands. You can see there has about 138 million incidents, as well as Asia, 75 million, Hispanics from South America, 25 million, as well as the black population also has a higher incidence of diabetes than that of Caucasians. And so when you factor in Hispanic Americans and African Americans and Pacific Islanders as well as Native Americans, they make up our populations that have the highest prevalence. So there's definitely been an alarming increase in type 2 diabetes prevalence in both adults and children. We've spent most of the time so far talking about adults, but children has definitely been, if you've been paying attention to the media at all, have noticed that children incidence of diabetes has definitely increased over the last decade. The CDC estimates that by 2050, every 15 people out of 1,000 people will be living with diabetes. That's 1 in every 3 Americans. So why it's even more important that we as a healthcare system learn how to appropriately help patients with diabetes, since it will be such an important part of healthcare. So what are some reasons you can think of to account for the rapid increase in prevalence of diabetes? Here I'm hoping they will be able to address obesity, the decrease in physical activity and poor diet that our pop culture promotes, our move toward more sedentary type jobs, desk jobs, high stress workplaces that don't allow for physical activity. But one thing I'm thinking they won't identify is that patients are now living longer with diabetes due to us being able to maximize their diabetes treatment and treat the condition much more holistically and more appropriately. So now we're going to jump right in and move right into some pathophysiology on how diabetes actually progresses. So before we do that, let's do a quick reminder of what peptides and hormones are secreted from what organs. If we know this, it will be much easier for us to identify the pathophysiology that's associated with diabetes if we can understand the normal physiology. So this is the view that they will see. So hopefully they will be able to identify from this that the insulin is secreted. The insulin and amylin are both secreted by the pancreas. The GLP-1 peptide is secreted by the GI tract. Glucagon is secreted by the liver, and SGLT2 is a peptide that is secreted by the kidneys to promote glucose reabsorption. So insulin. So let's start to talk about each of these peptides in detail and see how they all interplay that help regulate the normal blood glucose levels. So insulin is secreted by our beta cells of the pancreas. They increase their production with an increase in blood glucose. So how this happens, the liver decreases its glucose output. Sorry about that, I had a little interruption in my recording. So before we get into each of the peptides, we're going to discuss each of the peptides and think about how they relate to our glucose homeostasis. And so first we have insulin. As we know, it's secreted by our beta cells of the pancreas, and its production is increased with an increase in blood glucose, which is typically you eating. So the impact of an increase in insulin takes place in two locations. So first we have our liver, which is our powerhouse of glucose storage and glycogen production. So once our insulin is secreted, we see a decrease in glucose output. So the liver is decreasing how much glucose is being output by the liver. As a result, since it's not putting out glucose, it needs to figure out a way to store it. And so we get an increase in glycogen synthesis. We also get an increase in lipogenesis, which results in increased triglycerides. Our peripheral tissues we see an increase in the uptake that the insulin promotes by our muscles and our adipose tissue to remove the glucose from the bloodstream and retake it up into these tissues. We also see an increase in glucogen synthesis as well.